Hi, welcome back to our course on culture and health. Today, we're going to discuss cultural practices across the health continuum. I want to pose a question that I believe is worth pondering. Why do some of the best defined public health interventions fail to reach the people who need them most? We may invest great effort and resources in designing and implementing prevention campaigns, treatment protocols, rehabilitation programs. But then we watch participation rates stall in certain communities. The instinct is often to blame the community. They're resistant, we say. They don't prioritize health enough. They're hard to reach. They have deeply ingrained behaviors that are hard to change. But what if the problem isn't the community? What if it's us? The way we've defined the intervention, the assumptions baked into the delivery, the cultural blind spots we didn't even know we had. Our talk today is about seeing healthcare differently, not as a series of services we offer, but as a relationship we build, one that has to work across the entire journey from prevention through treatment to recovery. And at every stage, culture shapes whether that relationship succeeds or fails. We're going to move through the continuum of care today: prevention, treatment, rehabilitation. At each stage, I want you, I want to invite you to think not just about what services exist, but about who actually accesses them, who doesn't, and why. So, what do we mean by continuum of care? This is the idea that healthcare isn't a single encounter, but instead a journey: prevention, treatment, rehabilitation. Ideally, these stages are connected and coordinated, not fragmented into silos where patients fall through the cracks. The concept matters most when we're talking about health disparities. Fragmented care disproportionately harms communities that already face barriers: linguistic, economic, geographic, historical. When care isn't continuous, the people with the fewest resources to navigate a broken system suffer the most. Now, this is where culture comes in. Every stage of this continuum, cultural beliefs and practices shape how people engage or don't engage with health systems. Whether someone shows up for a screening, whether they trust the results of a diagnosis, whether they follow through with treatment, whether rehabilitation feels like genuine healing or an externally imposed process. Understanding these influences isn't merely a nice to have. It's the difference between interventions that work on paper and interventions that actually work in the communities that are meant to be served. So let's walk through each stage. Okay, let's start with prevention. Prevention is where public health should shine. Catch problems early, or better yet, prevent them from occurring entirely. This is done via screenings, vaccinations, health promotion campaigns. The logic is clear, but here's a more complex reality. Prevention programs often show the starkest disparities in uptake across cultures. The communities most at risk are frequently the least likely to participate. And if we're honest, traditional public health has often responded by doubling down on messaging, as if the problem was simply that people just don't understand how important this is. But that's rarely the actual problem. For example, let's consider vaccine hesitancy during the peak of the COVID-19 pandemic. We saw significant variation in vaccination rates across communities. A study by the Kaiser Family Foundation found that in December of 2020, 35% of Black adults and 26% of Latinx adults expressed reluctance to get vaccinated, compared to just 20% of white adults. Now, our temptation may be to lump this together as hesitancy and treat it with more information. But the drivers were very different across communities. And of course, communities aren't a monolith. So I'm going to be offering some general observations based on the research, but let's keep in mind that there's a lot of variation within each one of these communities. For many Black Americans, the shadow of the Tuskegee syphilis study loomed large. This was a study that surprises many when I narrate the length and the impact that it had. It lasted over 40 years, a government run experiment where Black men were deliberately left untreated so that researchers could observe the progression of their disease. Unfortunately, that history isn't distant memory. It is one dramatic example of chronic, recurring instances of health injustices that shapes how healthcare institutions are perceived today. On the other hand, for Latinx communities, the picture was more complex. Nambi Nduga and colleagues at Kaiser found that immigration concerns, the fear of deportation, and past experiences of healthcare discrimination were often more salient than concerns about vaccine safety itself. Specifically, in the case of undocumented migrants, showing up at a vaccination site felt like a risk, not because of the vaccine, but because of who else might be watching. So, what worked? Meeting people where they were, literally and culturally. Vaccination drives at churches, community centers, trusted local clinics, messaging delivered by community members instead of by government officials who can sometimes feel detached from the context. Multilingual materials that didn't just translate words, but translated meaning. Now, let's look at healthcare screenings, which show some similar patterns here. Mammograms, colonoscopies, cervical cancer screenings, these are straightforward medical procedures, but participation rates vary dramatically across cultures. Erica Torres a researcher studying Latina health, published a work in 2022 examining why cervical cancer screening remained low in particular Latin American communities. What she found in this study was that a key factor was the sense of modesty, the cultural norms that associated gynecological exams with married women, and the sense of discomfort with male providers or with impersonal contexts. All of these were key factors. Similarly, in the case of South Asian and Middle Eastern communities, preferences for gender concordant providers, particularly for breast exams, significantly affect screening participation. These aren't irrational barriers. They're cultural values that the healthcare system needs to accommodate, not dismiss. Effective interventions shouldn't just tell people why screenings matter. They should ensure access to female providers when that matters. They frame health messages within cultural narratives that resonate. They involve community members in designing outreach rather than treating communities as passive recipients of expert wisdom. I have been focusing on the need for female healthcare providers, but another issue that has been growing is the disproportionate prevalence of female healthcare providers, which is not declining, but increasing. There is a gender gap where healthcare professionals are predominantly female. And one of the issues with this is that some men may lack the confidence and may perceive some obstacles to discuss and address their healthcare needs. This is why we should ensure that the healthcare system is as diverse and inclusive as possible, looking at the specific needs across cultures, but also across genders. Now, let's move on to the next stage, treatment. Okay, good. Someone has decided to seek care. Prevention, whether it was successful or not, is behind us at this point. The patient has overcome whatever hesitation they had about prevention. Now they need the actual treatment. What stands in the way? Language is the most obvious barrier, and it's more consequential than many providers realize. Glenn Flores, who's a pediatrician and health services researcher, has documented extensively how limited English proficiency correlates with lower rates of preventive care, more emergency room visits, and poorer chronic disease management. When you can't communicate your symptoms precisely and confidently, when you struggle to understand the discharge instructions, when you feel pressed to nod along to a treatment plan that you don't fully grasp, then outcomes invariably suffer. Federal law mandates interpreter services in federally funded healthcare settings. But the gap between mandate and reality remains very wide. Many clinics still rely on family members, including children and grandchildren, to interpret. Likewise, there may be ad hoc interpretation by staff, by healthcare staff that may not be properly trained in medical translation. Likewise, in both of these cases, the case of untrained healthcare staff and family members, the quality of the translation may be very irregular because these persons may not be fully bilingual. They may have a limited command of either English or the language that is being translated from and to. Phone-based services sometimes feel impersonal and create delays. When translation occurs in subsequent segments, so a healthcare provider says one sentence or paragraph, if the translator proceeds to translate that message, then that may increase the duration of the exchange by doubling or tripling it. Given how crunched for time so many healthcare providers are today, that is something that is practically difficult for doctors and nurses to accommodate. They may have the best intentions, but they may simply not have the time and have limited patience for that type of translation. The result of all of these issues is that patients who most need clear communication often receive the least. Transportation barriers are easy to overlook if you haven't faced them directly. Said and colleagues published research showing that 5.8 million Americans delayed medical care due to transportation issues. This may happen in rural communities. It may happen in urban neighborhoods with inadequate public transit. It may happen when there is urban violence that makes reaching the health center difficult. It can happen when elderly patients are no longer able to drive. So the appointment exists, but they simply can't get there. And then there's mistrust, which runs deeper than any single barrier. William Hammond, who's a health disparities researcher, argued that while historical events like the Tuskegee experiments that I mentioned before do matter, it's ongoing experiences of discrimination in healthcare settings that contribute more to current day distrust. It's not just what happened decades ago, it's what's happening now. How was the last appointment? The perceived dismissiveness, the false assumptions, the feeling of not being believed, of not being fully seen and treated with respect. Strikingly, a 2022 Pew Research Center study found that 43% of Black adults reported lower trust in healthcare providers, compared to just 23% of white adults. Similar patterns show up among Latinx and Native American populations. This isn't merely a communication problem to be solved through better outcomes. I'm sorry, through better brochures. It's a relationship problem that requires systemic change, more diverse providers, meaningful bias training, and most importantly, different behaviors in clinical encounters over time. Telehealth emerged or popularized during COVID-19 as a potential solution to many of these barriers. And in some ways, it has delivered tremendous value. You can overcome the issue of transportation, among many others, busy work schedules, complex family demands, and so on. Remote consultations can bring great convenience. Flexible scheduling helped people who couldn't take time off work. But telehealth also reveals new disparities. Jorge Rodriguez and colleagues at Brigham and Women's Hospital in Boston found that Latinx and Black patients were less likely to use telehealth services. Why would the communities that may most benefit from the convenience of telehealth use it the least? The reasons are varied. They include limited internet access, lower digital literacy, language barriers on platforms designed for English speakers, and legitimate privacy concerns, especially in households where multiple generations share limited space. So, what works? Rodriguez's team and others have pointed towards culturally tailored approaches, technical support for patients unfamiliar with video platforms, multilingual telehealth options, and integration of community health workers into virtual care teams. Hybrid models where patients can move between in-person and virtual visits based on their needs and comfort level. All of these show promise for maintaining engagement. As someone who has witnessed healthcare provision in English and different languages, one underappreciated obstacle when resorting to telehealth or when trying to navigate the healthcare system by phone or online is that there may be some multilingual messages, but they may be broken down. They may not be continuous throughout the process. Imagine calling a line where you are asked what language you want to speak, and you're given the options of English, Spanish, Mandarin, and whatever languages are most prevalent in that community, Amharic, etc. You may choose that language. You may receive some messages in those languages. But when you select the next options, the messages turn back to English. When the communication is broken down, what happens is the person that is not fluent in English hesitates to reach out and to make good use of that healthcare service. So it's not enough to have translation or 50% or for 75%. You need to have the continuum translated in the language of the community. A larger lesson here with telehealth is that technology doesn't automatically solve equity problems. Sometimes it may create new ones. Designing For equity means thinking about who's being left out, not just who's being served. Treatment addresses the acute problem. Rehabilitation is about what comes after recovery, reintegration, and sustained well-being. This is where the limitations of a purely biomedical model become most apparent. I'm going to read this out because it's a key message. Rehabilitation extends beyond medical treatment, requiring culturally responsive approaches that address social determinants of health. Community-driven models emphasize local participation in designing and implementing health services. Recovery doesn't happen in a clinic. It happens in communities, in families, in daily routines. And if those contexts are ignored or worse, undermined by interventions that don't fit, rehabilitation stalls. Community-driven care models recognizes they shift power from external experts to local participants. The community isn't just a recipient of services, they're involved in designing and delivering them. The quote that we saw above here, this comes from Joseph Gone, a psychologist who works with indigenous communities. And he has written extensively with Lawrence Kiermaier about what this looks like in mental health and substance use recovery. Programs that incorporate traditional healing practices alongside Western clinical approaches show better outcomes. Not because traditional practices are magic, but because they restore agency. They connect individuals to cultural identity and create healing contexts that feel legitimate rather than imposed. Now, community health workers, CHWs, can be another powerful tool. These are individuals who share cultural backgrounds with the populations they serve. They bridge the gap between formal healthcare systems and community realities. Walker Poston in 2015 led a demonstration project in California targeting church-going Latina women, a community-based physical activity intervention delivered through faith organizations. This project worked because it met people in spaces they already trusted. It used culturally familiar frameworks and was led by people who understood the community from the inside. Likewise, Linda Frost and colleagues showed similar results when working with Latino farm workers. Promoting safety behaviors like protective eyewear through CHWs could deliver, these CHWs could deliver messages in a way that resonated both linguistically and culturally. These shouldn't be viewed as peripheral interventions. Instead, they're models for how healthcare can actually reach communities that formal systems have failed. This was my personal experience as well as country director of Heartland Alliance, an international nonprofit specialized in mental health and psychosocial support in complex environments. I led this organization in Colombia. This was between 2016 and 2018. And we had an innovative model that was developed in collaboration with a regional public university in Colombia and with Johns Hopkins University in Baltimore. And this model relied on community health workers who were often Afro-descendant women who were survivors of the conflict. And they were playing a leadership role in their communities. So they had earned a certain degree of trust and had legitimacy when engaging. These persons were trained and they collaborated with professional psychologists and social workers. And we found that this model allowed for us to not only extend the services in a far more cost effective way to a much larger population, but the treatment itself was far more effective. In fact, there was a medical study that compared the effectiveness of the treatment in reducing symptoms related to depression and anxiety within these communities and in clinical settings in the US and found key advantages based on the way that it was done in these low income, complex environments. Of course, this isn't replicable in every context, and it has to be done with care, but it's nonetheless striking to witness just how transformative community health workers can be. Now, traditional healing practices deserve special attention. The World Health Organization, WHO, estimates that 88% of African populations and 76% of Asian populations use traditional medicine as a primary healthcare resource. This may include herbal remedies, spiritual healing, indigenous medicine, and these aren't simply relics for these communities. They are living practices that millions of people trust and use. In rehabilitation settings, dismissing these practices means dismissing the patient's entire framework for understanding health and recovery. Now, the medical efficacy of these practices can be very irregular, but engagement must begin with respect. So, respecting these practices and, when positive, integrating them with patient consent may help enhance trust and treatment adherence. In Canada, its Truth and Reconciliation Commission reported in 2015 on the legacy of residential schools that had such a profound impact on Native American populations and called for healthcare systems serving indigenous populations to include access to traditional healers and ceremonial spaces. Some hospitals have responded by creating healing rooms, inviting elders into care teams, and recognizing that recovery for Indigenous patients may require reconnecting with cultural practices that colonization tried to destroy. This is what culturally responsive rehabilitation looks like. Not replacing traditional practices with biomedical ones, but creating spaces for both and letting patients navigate between them in ways that make sense for their lives. From my own experience leading Heartland Alliance and working with community health workers, I saw this dynamic constantly. Afro-descendant communities had rich traditions of mutual support, spiritual practices, and community healing that predated any NGO intervention. The programs that actually worked weren't the ones that arrived with predetermined protocols. They were the ones that asked what already exists, and crucially, how can we strengthen them? Because if you don't recognize what already exists, you run the real risk of imposing something that disregards and inadvertently weakens existing capacities. Okay, let me bring this together with some key takeaways that can carry us into practice. The first point I want to make is that prevention requires cultural tailoring, not just cultural translation. So, vaccination campaigns, screening programs, health promotion, all of these succeed when they address the specific beliefs, experiences, and concerns of distinct communities. What works for one group may fail completely for another. The next point I want to emphasize is that treatment barriers are multiple and interacting. Language, transportation, mistrust, all of these, they don't happen in isolation. A patient may face all three simultaneously. Effective systems address barriers in a comprehensive way, not in isolation. Next point, given the prevalence that telehealth has had, especially since the onset of COVID-19, is that this is a tool, but it's not a solution in and of itself. It can expand access or deepen disparities depending on how it's designed. Equity requires intentional effort, multilingual platforms, technical support, hybrid models, community health worker integration. The next point is that rehabilitation is cultural in nature because recovery happens within communities, not in clinics. This is why community-driven models and traditional healing practices, they aren't simply alternatives to evidence-based care. They are what can make evidence-based care actually work for diverse populations. And the last point I want to make is that trust is built very carefully over time through behavior, not through messaging. Messaging is insufficient for trust building. Historical trauma is real and it matters. But contemporary experiences of discrimination matter even more. Systems can earn trust by changing how they treat people, not by telling or explaining why people should trust them. So, as we wrap up our session today, here's a question I want you to hold on to. At every stage of the health continuum, from prevention to treatment to rehabilitation, who isn't showing up? And you must hold back the temptation that is all too real of asking what is wrong with them. Instead, ask what's wrong and what can be improved with how we have defined the system. That reframe is transformational. It's the foundation of culturally responsive care. Start with the assumption that communities act in a rational, in a sensible manner, that their hesitations have validity, that their practices have value, and that they have great resources and strengths. Then design systems worthy of their trust that can leverage and build up those existing capacities. Thank you very much. That's all for today.